Okay, hi everyone. I think everybody's joining at the moment, so welcome all. Thank you for joining us today for the 7th session in our Age-Friendly Geriatrics Tele-Echo series. This topic has been adjusted. We had a previous speaker that could not make it today, but today's session is going to be focusing on managing depression, anxiety, and insomnia in older adults. So again, thank you for being here today. We're going to follow our, the same agenda that we usually follow with our introductions and announcements in the beginning, moving on into our didactic, and then following with some reminders at the end of the session. Just to let you know, you are muted upon entry. So if you do have any questions, feel free to unmute yourself and just introduce yourself and ask a question if you'd like. Today's session is CME accredited. You will receive a maximum of a 1 AMA PRA Category 1 credit. Physicians should claim only the credit commensurate with the extent of their participation in the activity, and the California Board of Registered Nursing does recognize CME credits as transferable for their members, so nurses can receive CEUs after submitting their UC Irvine attendance certificate directly to their board. I have received a few questions in the past. Usually we submit your names and everything of whoever has submitted the CME info that we send after the session. We send it in about a week after the session, and our CME department will send out their certificates within 2 to 3 weeks to your email address. So just be on the lookout for those. They will come through to your email address. And just to let you know, Dr. Geriatrics does have a faculty disclosure, and she's disclosed that she serves on an expert panel on the management of agitation using an interdisciplinary approach and non-pharmacologic means. This series is grant funded by the Health Resources Services Administration. Any content and conclusions are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. As we always do, we do like to do introductions. We like to see where you're here from. And this also helps us make sure that we know who's here today, who can receive CME credits. So please go ahead and put in your name, your role, your site, and your location in the chat, please, as we go ahead and introduce our hub team. Dr. Sagal couldn't join us today, but I will go ahead and get us started. And my name is Nika Seville. I'm the project manager for our Geriatric Workforce Enhancement Program here at UC Irvine. We are located in Orange, California, and I will go ahead and have Dr. Pereira introduce herself.
Hi, everyone. Welcome. So I'm Manisha Pereira. I'm one of the geriatricians here at UC Irvine. I am located in Orange, and I work at the Senior Health Center. Welcome.
Thank you, Dr. Pereira. And PA George?
Hi, my name is Valerie George. I'm a physician assistant, and I work at Senior Health Center in our Orange Clinic. Welcome to everyone, and hope you enjoyed the lecture today. Thank you.
Thank you so much. We'll go ahead and move on into our session on managing depression, anxiety, and insomnia in older adults. And Dr. Geriatrics is on the line. And if you've been at our previous ECHO series, she's presented quite a few sessions, so you might already know her. So Dr. Geriatrics, I'll go ahead and let you take it over.
Thank you for having me. And let's start. So next slide. So we're going to talk about a couple of things today: how to manage sleep in older adults, a little bit about the sleep architecture, and then we're also going to talk about management of anxiety and depression, specifically as it relates to medications. I don't know if these objectives are representative of the slides, but that's okay. Next slide. So let's start with insomnia. So insomnia is obviously really common in older adults. In the average population, it happens in about 6 to 18% of the public. With older patients, it's close to 60%. Most patients complain of having sleep issues, and not getting good sleep is a very costly thing. It leads to billions of dollars annually in direct and indirect costs. And in terms of quality of life, it leads to daytime dysfunction, depressed mood, poor quality of life. and actually, obviously increased falls, which is something we're trying to prevent in older patients, and even increase in mortality. Next slide. So what are some age-related sleep changes that happen? So first of all, there's a decline in sleep quality and duration. So if patients' expectations are that they're going to sleep as well as they did when they were 30 or 40, it's really not a realistic expectation for them to have. So that's something we could do in terms of education. Typically, sleep duration declines with age, and so does sleep quality. And the amount of time we spend in deep restorative sleep also diminishes. There's also a weaker circadian regulation that happens as we age. So, and what ends up happening is patients are more tired, more sleepy during the day, and much more awake at night. And we see that especially in those who have dementia or cognitive impairment. So typically older adults experience more frequent awakenings throughout the night, early morning awakenings without the ability to go back to sleep, and increase in sleep latency, which makes them unable to fall asleep quickly. Next slide. So just to review basic sleep stages, we've got stage 1, where it lasts anywhere from 5 to 30 minutes, where there's mental relaxation, eye closing, and kind of your body getting set up to go to sleep. Stage 2 is less deep sleep. You're generally disconnected from the outside world, and you can't hear normal noise, but you might be able to hear like a door slam or something that's jarring. And most of the time, people spend close to 50% of their sleep time in sleep. Stage 3 and 4, you spend about 15 to 20% in that, and it's deeper sleep. That's the restorative sleep you have, where you're able to wake up the next day and kind of do daily activities without much trouble. So this is the kind of sleep you actually need. And then you've also got your REM sleep, which is your dreaming stage. Next slide. So when you look at this picture of sleep physiology in older adults, you see dramatic changes from what happens when you're younger to the older adults. Generally, older patients take longer to fall asleep. So stage 1 typically extends. Stage 2 extends as well. And this is, so it extends and it becomes more impaired. So you're more easily awakened from that sleep. Stage 3 and 4 generally shortens. So overall, as we age, we spend less time in deep sleep, or that restorative sleep that we desperately need. And REM sleep is also shorter in older adults. Next slide. So that creates some issues for older adults in sleep. So typically they don't get the kind of sleep they used to get. And so there's a lot of complaints that go along with that. So what do hypnotics do to the sleep cycle? The typical things we use, like Ambien, Lunesta, Sonata, some of the benzodiazepines, they typically shorten stage 1. So you do fall asleep a little bit faster. They typically extend stage 2. So what ends up happening is that patient spends more time in that non-restorative, easier from awakened sleep cycle. They actually shorten the deep sleep. They shorten stage 3 and 4, and they shorten REM. So you typically have less dreaming going on when you take these drugs. And patients, what typically happens, patients report falling asleep without realizing they're asleep, doing something in the middle of the night, presumably sleeping, with no recall of that. And then they wake up in the morning with something awakening them, sometimes an alarm clock, and they don't have any recollection or any sleep memory of being asleep. So it's a very different type of sleep that you get from benzos and the Z drugs. Next slide. So what they've decided is that we really don't have a lot of good sleep options in terms of medication. So really non-drug therapy is much more effective than any medication we can prescribe. And this is not new data. This is from 2006, but it looked at 23 meta-analyses of trials of cognitive behavioral treatment, relaxation, sleep hygiene education, combinations of all of that. And what they found is that kind of an approach improves sleep efficiency, improves sleep quality, decreases sleep latency, It's really overall beneficial, more beneficial to any pharmacologic intervention we can recommend. Next slide. So the best thing you can do for your patients who are complaining of insomnia is spend a little time doing sleep hygiene. And if you don't have the staff to do that in your office and you don't have time to do it yourself, like in our clinic, sometimes patients refer to me and I spend about a half an hour going over some basic sleep hygiene principles so that they can try those before we resort to medication. So these are some of the things you talk about. Regular sleep schedule, and the patient can adapt that to their own activities. You should go to bed only when you're sleepy. You should cover the alarm clock and not look at the clock every 15 minutes when you're not able to fall asleep, because all that does is creates more anxiety. You should avoid taking long naps. Anything 20 minutes or longer would be considered long. You don't want to toss and turn in bed. You want to get up, go do something relaxing, and try again in about a half an hour or so. You do want to get on a regular exercise regimen with exercise, including some outdoor time. And you also don't want to exercise late in the day, right before you go to bed. You want to avoid large meals at night. You want to limit your caffeine intake to morning or early afternoon only. You want to limit your alcohol intake because that can cause really disruptive sleep. You want to make sure your bedroom environment is comfortable with comfortable beds, blankets, pillows, temperature. No lights flickering or penetrating into the room, which sometimes happens with TVs, cable boxes, lights from the outside. And you want to do something relaxing before going to bed. And the first step really is to try something like a melatonin or an L-tryptophan rich food as a small snack before you go to bed to see if that relaxes you enough to be able to fall asleep quickly. Next slide. So here's a slide of all the caffeine content of foods. I think it's really interesting. Sometimes caffeine is there and we don't realize it. Like when I put the slide together, I had no idea that Mountain Dew, for example, had some caffeine in it. Depending on where you get your coffee, you could either get a little bit of caffeine or a lot. You know, Starbucks brewed coffee grande 16 ounce, that's 320 milligrams of caffeine. Just to give you a benchmark, if you were to buy caffeine pills over the counter, like No-Dose or Vivarin, those have 200 milligrams of caffeine. I don't know if you've ever taken them. When I was at college, I think I took some and I was up for quite a long time at night studying for exams. So 200 milligrams of caffeine is a lot. So 320 is a lot when you're dealing with an older adult. Tea has some caffeine depending on how you brew it. And even, you know, Ben and Jerry's ice cream has a little bit. So just keeping an eye on that could be important in improving quality of sleep. Next slide. You also want to look at some medications that can contribute to insomnia. Diuretics being one. You know, if they're being administered, you want to make sure patients are taking them in the morning, not in the evening. And very often when I go through a medication list with a patient, we realize that they're on some kind of a combination with a diuretic in it, and they don't realize it has a diuretic in it, and they take it at night. So that's something to look at. Dopamine agonists can produce disturbing sleep. Some antidepressants, like more activating ones like Wellbutrin or bupropion, and something like fluoxetine or Prozac can sometimes cause disturbing sleep. Thyroid replacement, if somebody is either hypo or hyperthyroid, that can cause problems. Sometimes hormone replacement therapy can contribute to insomnia. And then you also want to look at their herbal supplement use, because a lot of them will have caffeine related products like either caffeine or guarana or ephedra or green tea extract, very common in some of these preparations. Some antipsychotics can cause insomnia. Dementia medications can do it too, sometimes causing a lot of vivid dreams. Steroids occasionally will do the same thing. You also want to look at the over-the-counter stuff. A lot of decongestants will have them, and a lot of decongestants are in combination products like Claritin D, Zyrtec D. So you want to look at that to make sure they're not taking that. Beta agonists, most of them are administered via inhaler or nebulizer treatment. Inhalers generally are pretty well tolerated, but when you do a nebulizer treatment, sometimes that can cause a little bit of tachycardia, palpitations, and that can produce make you less able to fall asleep. Obviously, appetite suppressants can do the same thing in ADHD meds. Next slide. Unfortunately, in a primary care setting, there's lack of time and resources to really provide good sleep hygiene education. So we always resort to sort of quick fixers to improve sleep. And most of them are on the Beers list, the Beers criteria, which is a list of inappropriate medications in older adults. So antihistamines that are available over the counter, for example, like diphenhydramine and doxylamine, are not appropriate to use in older patients because they can produce confusion, cognitive slippage, and sometimes even delirium. And these antihistamines are packaged in a bunch of Tylenol preparations, Advil preparations, a lot of cold and cough things, like things like NyQuil will have a bunch of these. So you have to be careful with the over-the-counter products that patients take and review them with your patients. The benzodiazepines and the Z drugs are also on the Beers criteria for increased risk of falls, dizziness, confusion, cognitive impairment. So you really don't want to use these drugs in older adults, especially those with those underlying issues as well. Things with tricyclic antidepressants, which can be sedating and can be used for insomnia in younger patients, really, it's not appropriate to use them in older adults because, again, of the anticholinergic content of these drugs, which can produce more confusion and also orthostatic changes. And then you can get next day sedation and dizziness if you use things like gabapentin, quetiapine, or Seroquel, and trazodone at higher doses. So you really want to be careful with those as well. So that there's not, the options we have for sleep aren't great from a pharmacologic standpoint. So that's why hygiene is really the way to go. Next slide. So there's also quite a bit of data, which is not new anymore. It's fairly old data, but it really speaks to the dangers of using these sedative hypnotics in older adults. So this data is from 2005, British Medical Journal, and it looked at 24 randomized controlled trials that evaluated sedative hypnotic use in over 2,000 patients. And so what they found is the number needed to harm or to cause a side effect is 6. And the number needed to treat is 13. So what that says is that you're more likely to get a side effect from these medication than a therapeutic outcome. And the kinds of side effects you see are things like drowsiness, fatigue, headache, nightmares, nausea, loss of balance, dizziness and falling, motor vehicle accidents. Obviously all these things lead to broken bones and things like that. Next slide. There's another meta-analysis of risk of benzos and benzodiazepine-like drugs in older adults. So there were 6 studies of a total of 441 patients. And what these drugs showed to do is decrease the number of awakenings by less than 1. And another 6 studies of about 300 patients showed that the number of awakenings decreased by again, less than 1. Do you want to give a drug with potential adverse outcomes from the get-go to only achieve, less than 1 awakenings? I don't know that they're worth it. That's the whole point. And when you look at increased sleep time, they only increase sleep time by about a half an hour. So again, looking at objective data where they're collecting that information, it's really not, these things are really not that effective. Next slide. There's also a significant cost associated with benzo use. And, this cost include things like emergency room visits, inpatient admissions, and multiple outpatient visits as a result of some kind of an adverse event stemming from benzodiazepine use. Next slide. So what's wrong with the with the non-benzodiazepine hypnotics? If you look at the data, they're dangerous as well. Since the advent of Ambien, for example, the ER visits have increased by over 200% due to its use. Lots of reporting of hip fractures in nursing home patients, more likely to have other kinds of fractures, even from more likely than with a short-acting benzodiazepines. So in some cases, these Z drugs are more dangerous than using a benzo, which is scary. And then you also have these weird behaviors, like you get this amnestic syndrome where patients do something in the middle of the night and have no recollection of doing it. So they'll get up, they'll make dinner, they'll call a friend and try to talk to them or a family member. And in the morning, they have no recollection of doing it. You have reports of patients getting into their cars the next morning after taking an Ambien, for example, driving, hitting a pedestrian, and again, not being able to recall that. So all these things kind of add up to this picture of these drugs being not very safe in this patient population, and all the references are listed there. Next slide. So on paper, though, they look pretty good. You know, these are the common ones, the benzodiazepine-like drugs that we use. So Lunesta, onset of effect, they all have about 30 minutes, Lunesta, Sonata, and Ambien. Sonata, I think it's a little bit shorter than 30 minutes, but roughly around a half an hour. Half-life is very short for Sonata, it's about an hour. So I think when the drug first hit the market years ago, the drug reps were saying, well, you can administer it more than once. If you wake up in the middle of the night, take another one. Because the half-life is so short. So they do have short half-lives. You know, Lunesta, which is supposed to be the longer acting one, is only 6 hours. Ambien, immediate release Ambien, is also on the order of, 3 to 4 hours, with sustained release things that are closer to 6. So on paper, they look good. But in reality, even that short half-life, it still translates into early morning grogginess and problems in the morning with cognitive function, dizziness, and falls. Next slide. So what are some of the other options? So we've got herbal supplements. Melatonin is quite popular, and melatonin, I think, has a place in therapy, but you have to know how to use it. So if you've got a patient who's got night and day a little bit mixed up with taking longer naps during the day and not able to fall asleep at night, melatonin can be effective. The real issue is how much melatonin. So, and the dose really varies. So there's some formulations with as little as 1 milligram all the way up to 10. The highest dose I would be comfortable with is using maybe 15 milligrams of melatonin, but you got to work with it. You know, sometimes they try 3 milligrams, it doesn't work. 6 milligrams doesn't work, but 9 will. So you have to kind of be a little bit more patient with it and trial it over that dosing range. Chamomile can be effective. It doesn't really knock you out and put you to sleep, but if there's an underlying anxiety component, it can relax you and allow you to fall asleep more easily. You have to worry about allergies because I think there's a cross-reactivity with ragweed and chamomile, so some patients are allergic to it. Valerian root is also popular. I don't like it as much because it is related to a benzodiazepine in structure. So, it can cause some dizziness, increased risk of falls, and you certainly don't want to use it in a combination with a bunch of other psychotropics because it can cause adverse events there. So valerian root is my least favorite one, but melatonin and chamomile are fairly safe. Next slide. You've also, if melatonin works, but not entirely, or you've tried, you get a little bit of a benefit, but not fully, you can try Rosarum. Rosarum is a pharmaceutical grade melatonin agonist, which can be used in patients who have sort of night and day mixed up. The dose is 8 milligrams, onset of effect is 30 minutes. And the half-life is fairly short, even with a metabolite. So duration of action is roughly 8 hours. Next slide. Trazodone, we still use a lot of trazodone in our clinic. The trick with trazodone, again, is dose. It may take a little while to get to a therapeutic dose. You start with always the lowest available, which is 25, and you go up. You go up to 50, 75, 100, 150. You kind of go up that continuum, making sure all along that the patient is not dizzy, excessively groggy in the morning and isn't having any cognitive issues as a result of an increased dose. But the advantage of trazodone, it's not habit forming. There doesn't seem to be a dose tolerance usually. It's safer than a benzo or a Z drug, for example. It can cause dizziness. If you're older and you've seen trazodone used as an antidepressant at higher doses, one of its major side effects is orthostatic hypotension. But again, the 25 to 150 dose is not a depression dose, so you don't see as much orthostasis with it. And then priapism, also very rare and usually seen in higher doses. Next slide. Then you've got mirtazapine. So mirtazapine is an antidepressant that at lower doses is also a good sleeping agent. So if somebody is depressed and having trouble sleeping, the target dose for insomnia would be 7.5 to 15 milligrams. It does increase the risk of restless leg syndrome, so you want to be careful with that. And it's typically used in patients who are also depressed. So you wouldn't necessarily use Remeron just as a sleeper. Next slide. Doxepin, this is an interesting one. This is low dose doxepin, so 3 to 6 milligrams. The brand name of that is Tylenol. It's typically more expensive than generic doxepin, but generic doxepin doesn't come in 3 or 6 milligrams. You got to use 10. So it's an old tricyclic antidepressant. At these low doses, it is sedating enough to help with sleep. And at that dose, it's not supposed to give you as much anticholinergic problem. So it's actually on the Beers criteria, they exclude this formulation of 6 milligrams from their anticholinergic drug list. So you can use it more safely. When you look at data that caused Tylenol to be approved, it increased sleep time by about an hour over 4 weeks. So not hugely effective, but somewhat effective. Next slide. And then for your non-geriatric patients, you can still use your antihistamines. We definitely don't want to use it in older adults because of the anticholinergic profile and risk for dizziness, sedation, excessive sedation, and cognitive impairment, which is a big deal with older patients. Next slide. You've got this new class of medicines, or relatively new class, the orexin receptor antagonists. I think there's just 2 on the market. Belsorma was the first one to hit the market, and the second one is Dayvigo. And they work differently. They actually block orexin receptor 1 and 2, and they inhibit wakefulness. So they work a little bit like propofol, kind of. So they don't put you to sleep, they just block you from being awake. The major side effects of this is daytime sedation, behavioral cognitive changes, and sleep paralysis. And the requirement for using these is the patient stay in bed for at least 7 hours if they're going to take it. So that's a problem with most of our older adults that wake up frequently to go pee, right? And it has to be taken within 30 minutes of going to bed, because you also don't want to be up and about when the drug hits. Also, lots of drug interactions and other interactions with CNS depressants and other psychotropics. So I don't think they're very easily administered in an older adult. Next slide. So this is a study this is actually, you have to look at the details. So this is a study, I think, published in JAMA, which is a good journal, right? So Dayvigo, comparison to Ambien in older adults. So this immediately catches our attention, of those of us who are in geriatrics, because wow, a drug for insomnia in older patients. Well, when you look carefully at this study, first of all, it's manufacturer sponsored. It's a 30-day duration, which is fairly short. And you look at the patient selection, average, so age range is 55 to and over, right? With a mean age of 63. Mean age of 63 means that most of these patients are 55 and a little bit over 65, maybe 65. That's probably the range. So that's not an older adult we deal with in primary care geriatrics. Our average age is 85. So these patients are definitely excluded from this trial. And if you look at further exclusion criteria, they exclude all kinds of medical issues: COPD, sleep apnea, nocturia, renal impairment, any kind of psychiatric disease, and malignancy. So again, that eliminates sort of your complex geriatric patients that you commonly see in clinic. So I don't know how reproducible these good results are in a more frail older adult. And sure, compared to Ambien 6.25 with Dayvigo 5 milligram, which would be the appropriate dose for older adult, the lower dose, they found Dayvigo to be more effective with few falls and sleep paralysis cases reported. But again, this is a much younger, healthier population. Next slide. So basically, non-pharmacologic therapies work best. You want to utilize your appointments for sleep hygiene. You involve your healthcare partners, you know, from the interdisciplinary team if you have access to them. You know, social workers, psychologists, pharmacists. You know, nurses can do a sleep hygiene visit as well. So if you train them, they're qualified to do that as well. Medical assistants. So however you do it, I think it's worth it. And then, you know, drug therapy is of limited value with potential for adverse outcomes. Some supplements may be useful. And really, drug therapy should be only used as a last resort when you've tried all the non-pharmacologic things. Next slide. So now I want to spend a little time going over management of depression and anxiety. Next slide. So as a pharmacist, I always look first at medications that can cause anxiety or depression in your patients. If we eliminate them, maybe these patients won't be anxious or depressed as a result. So for anxiety, you're looking for anything activating, like decongestants that are over the counter that we talked a little bit about earlier. Beta agonists, we also discussed. Bupropion is an antidepressant, which is more activating than the others. Fluoxetine, the same thing. Stimulants, steroids, and caffeine all can contribute to anxiety. And for depression, you've got some other things like beta blockers, for example. They're no longer first line for just plain hypertension, so they can be used in patients with other heart conditions like AFib or CHF. But remember, beta blockers slow everything down. Some of them are more lipophilic, and so they can get into the brain and make you more tired. And by slowing down the heart, they make it more difficult to exercise. So you have kind of low energy and really serious exercise intolerance. So they can cause this presentation of looking depressed. Clonidine is a centrally acting alpha agonist, which can cause sedation and sort of depressive symptoms in some patients. Obviously, benzodiazepines can do the same thing. Finasteride blocks testosterone synthesis, and so that can make patients also feel tired and maybe depressed looking. Progesterone can do the same thing. Sedating antihistamines can do the same thing. Muscle relaxants are all sedatives of some sort, so they can do that. Steroids either make you really anxious or really depressed sometimes, so that could contribute as well, especially oral. I'm not talking about inhaled. Narcotics obviously can do that. Some NSAIDs like indomethacin is on the Beers criteria for many reasons, but one of them is it's got this sort of idiosyncratic effect in older adults, and it can also make you depressed. And then some calcium channel blockers, especially those that slow down the heart, like diltiazem and verapamil. Next slide. So Beers criteria is full of anxiolytics and antidepressants. So anxiolytics have, and in the 2022 update of the Beers list, there's going to be a section on all the risks associated with benzodiazepine use. There's an increased sensitivity to them, more likely to cause confusion, dizziness, and falls, still quite addicting, increased risk of overdose, especially when using in a CNS cocktail, which includes opioids, are really not a good option. There is slow metabolism of most benzodiazepines in old age. I think the only exception is lorazepam, and it's probably the best tolerated benzo, but it's still badly tolerated. And obviously increased risk for cognitive impairment, delirium, falls, fractures, and increased risk for motor vehicle accidents. And in terms of antidepressants, they're also all on the Beers list. So that makes it a little bit of a problem of how to use them if they're on the high risk med list. But you do end up using them. So there is increased risk of falling and dizziness. So you want to start with a lower dose of these drugs and titrate up more slowly. You want to avoid things with an anticholinergic profile like tricyclics and paroxetine. Some of them can cause hyponatremia like SSRIs, SNRIs, especially at higher doses. So that's another reason to keep the dose to a lower end. You do have to do some dosing adjustments with a reduced kidney function. An example of that would be duloxetine. And then bupropion was removed from the 2019 Beers list because it causes seizures, but it causes seizures in everybody, not just older adults. So that's why it was removed. But it is an activating antidepressant, which can cause weight loss, insomnia, anxiety in older adults. Still, those are still the side effects, just not on the Beers list. Next slide. So just to show you, these are some of the common benzos we use. We don't want you to use them in older patients, and they're all kind of a problem with all geriatric considerations all being the same. You know, risk of falling, confusion, risk of falling, confusion. Clonazepam is something we sometimes see used, but it's a pretty long-acting drug with a fairly slow onset of effect. It peaks in about 1 to 4 hours, and the half-life is over 40 hours when you include all the metabolites. So it's a longer acting benzo that can accumulate with time. And that's why it's particularly dangerous in older patients. And things like lorazepam and alprazolam, they work more quickly. But alprazolam, for example, is incredibly addicting. In my clinical experience, I've never seen somebody being on alprazolam and not get addicted. They usually want to use it once, then they want to use it twice, and then want to use it 3 times a day, and then it's really hard to get off of them because I think the high you get from it is pretty substantial. So if you're going to use, so the half-life of alprazolam is 6 to 20 hours, not 620. That slide looks weird, and the half-life of lorazepam is 10 to 20 hours, not 1,020. So just to make sure that's clear. So I think of all the benzos that are available to us, I think lorazepam is probably the safest, again, because kinetics doesn't change with age. It's metabolized at the same rate as in a younger patient as in an older one, but it still causes the risk of falling and confusion. And I can't tell you how often it's been where, you know, patients want Ativan. We keep telling them, no, you're going to fall. Finally, we give in. We give them 1/4 milligram once or twice, and they fall the next day. So it can really happen. Buspar is an option for anxiety. It's an SSRI-like drug. It's a serotonin agonist. A typical dose, it's 5 to 60 milligrams. That's a range. Usually you start with 5 milligrams at bedtime and kind of titrate up slowly to about 30 milligrams. So 5 once or twice a day to start with, and then go up from there. It is a scheduled medication. It's not a PRN, should not be used. PRN doesn't work that way. It works very similarly to an SSRI, for example. And it is an option. I think it's a safe and effective option for anxiety in someone who really wants a benzo. It does take a little while to kick in fully, but once it does, it's effective enough. And it does give patients an option for a safer alternative when you're just managing anxiety without depression. Next slide. So in terms of antidepressant efficacy in older adults, it's just about as effective as all these antidepressants are just as effective in younger and older patients. Typical efficacy is about 50 to 60%. So they're not going to be effective in everybody. And that's why it usually takes a few trials of one or the other, like several drugs on the list to find one that actually works. They did a systematic review of 26 randomized clinical trials in patients 55 and over. Again, not necessarily geriatric, but they found no difference in efficacy. there are different side effect profiles, different withdrawal rates. And so you have to be very careful matching patients' symptoms to drug side effects so that they could get more benefit from the drug you choose. And in terms of withdrawal rates, you don't really see that if you carefully titrate the patient off. Obviously, they're generally speaking, when you use TCAs, they're not going to be recommended, and they have lots of side effects, so patients typically don't want to take them, and discontinuation rates are higher with them than with your traditional meds like SSRIs and SNRIs. And again, side effect profile and drug-drug interaction potential should really be the major determinants of selection of drugs in this patient population. Next slide. So this is a slide that kind of goes over most of the SSRIs that we use typically in an older patient. So this is citalopram, escitalopram, fluoxetine, fluvoxamine, paroxetine, and sertraline, some of the more established older options. So the ones we use the most would be citalopram and escitalopram. Escitalopram is probably my favorite. It's very potent. Low dose is quite effective. So the trick with these tables is the dosing. Like if you notice, the starting dosing doses here are much lower than they would be in an average patient. So for Lexapro, you might start with a 2.5 milligram, maybe 5, and go up to 10. With citalopram, you start with 5 to 10 and go up to 20. The reason the maximum is 20 for citalopram is because there's an increased risk for QT prolongation, and that's why you don't want to go beyond that. Fluoxetine, generally not recommended because it's more activating, but we have a few patients on it. It's also got a very extended half-life. So sometimes one of the reasons it causes insomnia is because it sort of tends to accumulate over time, and over time will cause patients to have trouble falling asleep. But it is more activating. So if a patient is kind of low energy and needs a kick in the butt in the morning to get up, maybe low dose fluoxetine may be appropriate. Fluvoxamine we generally don't use because it's got many drug-drug interactions, very sedating, and really not recommended in older adults. I know for a little while they were trying it in COVID patients, and it caused significant side effects in older adults with COVID. Paroxetine is, we don't like it because it's got a little bit of an anticholinergic profile, and it's also very short acting. Immediate release Paxil is very short acting. So if they're not compliant with a regimen, it can really precipitate a withdrawal reaction. So that's one of the reasons we don't use it. And it's also a potent 2D6 inhibitor of the P450 system. So there's more likely to be some drug interactions. Sertraline, we use it a lot for anxiety and depression, actually. And, the key with sertraline is the side effect. It's diarrhea. It's very common, more common than with the other SSRIs. And so if there's any kind of irritable bowel syndrome going on as well, you probably don't want to use Zoloft. But otherwise, it can be effective starting with a lower dose of 25 milligrams and slowly titrating up. Next slide. This is a list of SNRIs that are available. I don't know if it's a complete list anymore because I think a few of them have come out since, but these are the stuff that we typically see in our clinic. So venlafaxine, desvenlafaxine or Prestige, and duloxetine. Of the 4 listed here, duloxetine is probably my favorite one because it can also be used in it really works well in painful conditions. So you can use it for anxiety, depression, and pain. All SSRI or SNRIs can increase blood pressure. With duloxetine, it's more balanced. So if you start Effexor in someone, it'll definitely cause an increase in more norepinephrine effect at higher doses. So then you get an increase in blood pressure. Duloxetine is a more even drug, so you see less of that as you go up on the dose. Duloxetine is a moderate 2D6 inhibitor, so there's a potential for drug-drug interactions, and it does have to be renally adjusted if creatinine clearance is less than 30. I don't know that there's much of a difference between the effect of Pristiq versus venlafaxine. I think one is sort of a metabolite or an isomer of the other, so I don't know that there's much of a difference. And things like Petsema, we don't use. It's got lots of side effects: nausea, dizziness, insomnia, increase in heart rate, blood pressure, sweating is common, so we generally don't use it. Next slide. So basic consideration for selection of an antidepressant really should be side effects. And if you can match the side effects to the patient's symptoms, those kick in first when you start treatment, so that sometimes they can be, the side effects of the drug can be helpful in managing some of the symptoms. But some of the things you'd be looking at are GI, so higher risk of nausea, vomiting, and diarrhea in some of these drugs, so you want to stay away from them. Sexual dysfunction is generally more common with SSRIs, but they're also possible with other drugs, SNRIs as well. And, a lot of patients don't like to talk about that side effect. They just don't want to take the drug. And so it might be worth it to discuss it a little more, because you don't want to diminish sexual function in someone who's still sexually active, and that adds to quality of life. You're always on the lookout for dizziness and fall risk, and that's why you want to start with a lower dose and titrate up slowly and really monitor carefully. Hypertension, you want to keep track of that, especially when you're using SNRIs, and especially effects are at higher doses. Some other precautions, SSRIs and SNRIs can increase bleed risk. So in combination with NSAIDs, aspirin, Plavix, and anticoagulants, you want to make sure when you start these drugs, there's not an increase in bruising and bleeding associated with it. Also with cholinesterase inhibitors as well. They're not on the list, but they can also increase the risk of bleeding. Low sodium is sometimes possible, especially at higher doses. So that's another reason to titrate up slowly and keep an eye on the electrolytes. Serotonin syndrome is possible, especially when you're doing these cocktails of an SSRI for depression and a little trazodone for sleep and a little tramadol for pain. So you've got, all of a sudden, you've got 3 drugs working on serotonin. And so you have to be careful with that. But that doesn't mean you can't use them. You just have to be monitoring closely. And when you're stopping one antidepressant and starting another, it's really strongly recommended that you cross taper. So reduce the current antidepressant usually by about half, start a new one at the lowest effective dose, and kind of cross taper over about a month. Next slide. And then you've got some miscellaneous agents. Again, we talked a little bit about bupropion being most activating, but again, there may be a place for it in older adults, especially those who are very low energy and need a little bit of a kick in the morning. It's also useful for like smoking cessation, so you can use that for that as well. And you just want to work. I'm just more worried about activating kinds of side effects like anxiety and insomnia. It can also, it doesn't have a sexual dysfunction side effect. So sometimes it's used in patients where they really can't tolerate an SSRI. Mirtazapine is really our go-to if patients are having trouble with losing weight, if they need to increase their appetite a little bit, or sleep better. And again, at lower doses, mirtazapine is a lot more sedating than at higher ones. And then there's Trintellix. I think so far it's brand only. It appears to be well tolerated in an older adult population, and there may be cognition improvement from that drug. At this point, we don't really use it yet because it's significantly more expensive and generally not covered by some insurances, and more difficult to get an affordable price for them. It does have a long half-life, so it may accumulate. So again, you have to be careful with the dosing. Next slide. So make a selection more carefully in your older adults with antidepressants. Start with a low dose. increase gradually, but you do want to go to a therapeutic level. It may require a longer time because of that slow titration to achieve the same results as you would in a younger patient. Avoid patients with an anticholinergic profile because it can cause increase in dizziness, falls, and increased risk of cognitive changes. And monotherapy is always preferred over polytherapy. So try a few different agents singly before you resort to polytherapy. I think when you resort to polytherapy, it may be worth it to refer to psychiatry because they're much better at these psychotropic cocktails than primary care. Next slide. Any questions?
There are a few questions in the chat. Ritu says, where do you get CBT? We don't have enough places to help patients.
Oh my goodness, that's not really a drug question.
Anyone else from our
Valerie or Dr. Pereira, can you address that?
or Val? Anyone?
Sure. I can start, and Val, you can add if you. I don't generally recommend CBD to.
No. I think
I'm
CBT,
sorry.
cognitive behavioral therapy.
Oh, I'm so sorry. CBT. So I think there is a place for CBT. I'm sorry, I misunderstood the question. Where do you get CBT?
Yeah.
Okay.
Like
So
resources.
yeah. So I usually talk with a social worker and see if there are psychologists who offer cognitive behavioral therapy. And I do have some patients who have used CBT and has had, I would say, some partial improvement. Yeah, sorry, not CBD.
So CBD, we generally don't recommend at this point because there's really not enough data in your frail older adults. I was just, I'm on a board of geriatric council for one of my pharmacy organizations, and we're going to be looking at a bill that allows cannabis to be used for chronic diseases as a compassionate measure. And the studies they're citing are actually large studies of over thousands of patients, but patients 65 and over are only 15% of them. And so they don't really have very old patients. They don't have patients 85 plus. So I don't know that there's data in those patients and cannabis use. Any other questions?
There's somebody says, what is the benefit of genetic testing with drug selection?
So a benefit of genetic testing will tell you whether patients have all the metabolic pathways in place to break down psychotropic meds to make them more bioavailable or more effective. So I don't, we have I know a couple of our providers have sent patients for this genetic testing, and they've identified particular antidepressants that may be more effective, but I don't know that genetic predisposition to have everything in place to metabolize the drug translates into clinical efficacy. I don't know that that's been definitively proven. Do you, Val or Dr. Pereira, do you have any experience with sending people to genetic testing?
I have not done that.
Okay. I know Dr. Sagal has, and I think it may not have been effective in every case. So, but that's what genetic testing does. It tells you whether the patients have these enzymes that break down drugs to make them activated, and whether they're slow metabolizers or fast metabolizers, whether these drugs stay in the system long enough to be effective.
I think Dr. Tabrizi, you have a question?
Yes, thank you for calling on me. I have another non-pharmaceutical question. It's just a fun one. Do you know if there has been any attempt or any studies on for elderly, especially for older adults, I must say. Any for light therapy, specifically red light therapy? I'm reading a lot about those things, but I was hoping to hear something about it within our group. But is there anything like that out in up for studies, or even consider if that would be a way of dealing with this kind of anxieties, especially with the sleeping issues, with anxiety issues, and all those things?
So that's a really interesting question, but it's not a drug question.
I know. I just threw it out as a fun fact.
Dr. Pereira or Val, do you know anything about
Or
that?
anyone on the line, you know, an
Yeah.
echo session.
Anyone, that's
Anyone on the
right.
line is more than welcome to, if they know an answer or have heard something, is more than welcome to speak up as well.
I know for me, sometimes I will try to insist on light therapy for dementia patients, because really they get kind of turned around with night versus day, and really try to associate people who, like if they're in a group home or boarding care, to make sure that, you know, there's light, even the sundowning situation, you know, to make the room very lightly indoor lighting too, to make sure that they're still seeing that. But as far as the other general population, I haven't had that experience. I'm not sure anybody else.
So I saw a question about PRN use for trazodone. I think Dr. Rahimi asked that. You can use it PRN. The only issue is, like, it depends on the dose. Like if they're not, if their effective dose for trazodone is 100 milligrams, for example, which is higher end, I don't know that it's, I mean, I guess you can, if that's what's effective and they're not getting dizzy from it in the morning or during the night, then I think it's okay to do PRN. And sometimes insomnia kind of goes in patterns. So sometimes you use it for a couple of weeks and then you get better and then you can stop. So I've seen patients do that.
Thank you.
Off and on use.
And another question to follow up on that. When you use medication like trazodone or mirtazapine, how much time do you give patient to know whether it's going to be effective or not?
So with trazodone, I think it works pretty quickly. Like I've had patients where I've titrated them up, and I usually bring them back every couple of weeks to see how it's going. Usually it takes 3 to 4 days for them to kind of figure out if it's going to work, and then they try it. And so a week to 2 weeks roughly. With mirtazapine, also probably a couple of weeks. I mean, with mirtazapine, it's kind of easy. You start with a low dose. That should actually be the 7.5 milligrams should be the most effective dose. So if your patient is frail and you start with half of that, then I would, as long as they tolerate 3.75, I would bring them up to 7.5 and give them a couple of weeks on that. And if that's not effective, then go on to something else or bump it up to 15. But 7.5 should be the more sedating dose.
Thank you.
It looks like we have a question about, what are your thoughts on Precedex, especially if agitation is the issue we are considering in the ED? I recognize not in primary care.
We don't use it in primary care.
Can you explain what kind of drug that is? I'm not familiar with that.
You know, it's not something I'm really familiar with. It's I think it's used in intubated patients. Maybe somebody on the line can talk about that more.
Yeah, I think this is Nana or Dr. Gervich. And thank
Hi.
you all for a wonderful talk. Yeah, Precedex is used typically in the ICU for sedation for patients who are intubated. And like Dr. Gervich said, we certainly do not use that in the outpatient setting at all, by any means.
Yeah.
It's a close cousin to clonidine, though. I think that's probably the closest thing that we could compare it to, but we certainly do not use it in outpatient care.
Thank you so much. And last question is there experience with Zoloft for sleep?
So my experience with Zoloft for sleep is kind of mixed. Sometimes you give Zoloft in the evening and it can be a little bit more activating. Like when Zoloft first came out on the market many years ago, it was called Zippy Zoloft. And sometimes you give it for sleep and patients are knocked out. So I never quite know what each patient is going to experience with Zoloft. So we usually give it at night. I mean, actually, you can give it either at night or in the morning and kind of see what the patient does. And then if they're more sedated during the day, you switch it to nighttime. If they're more activated at night, you switch it to daytime.
Thank you. Does anybody have any last minute questions? Thank you guys for your compliments in the chat. We really enjoy, offering these sessions, and thank you for our hub team for being here and all of you. We had about 70 attendees, so that's wonderful. Just to let you know, we do have the CME form here. You're more than welcome to scan this code also with the evaluation. I do have your names down, so I will submit these for CME credits, but it's always helpful for you to fill out the form as well. And that will also be emailed to you with these slides. And the recording is always sent in a few weeks, probably 2 weeks, to your email. And just to let you know, we have a few other sessions coming up on these dates. Usually it's always the same link that you've received to attend this session. So we hope you will attend, and I'm sure you've been receiving our reminders. So those reminders will keep going out. Usually we have sessions on Wednesdays and Fridays. So we hope to see you at our future sessions. Thank you again and have a wonderful day.
Hi, thank you.
Hi, thank you, Dr. Grovich.
Great job.